Differential diagnosis, things seem to be the same, but they're not. When a person come in, 5 people can come in with shoulder pain, seems to be this pain, but all 5 conditions are different. As a matter of fact, everybody's condition is unique. They kind of fall into categories. Differential diagnosis, doing these tests, the differential assessments are really cool because you can figure things out. For example, let's suppose a person comes in, the next 3 examples are going to be differential of low back pain. Person comes in with low back, now quite often the case history will kind of give you an idea. The person comes in with low back pain, and this one finds that low back pain gets worse when you exercise. Exercise makes the back pain worse. Most people back pain is better when it exercises. In this case, the back pain gets worse when it exercises, okay? So have you ever heard of neurogenic claudication? It happens when there's stenosis. Neurogenic claudication means as you walk, the legs get tired, kind of tired. It's a lack of blood to the nerves in the cauda equina. If you remember, the cauda equina is just below the spinal cord. Those are the nerve roots, the nerves inside from about L2 down to the sacrum, the cauda equina. Now, neurogenic claudication means there's a lack of blood to the nerves to the leg. But if you look at the cauda equina, these nerves go more than the plexes. If you remember the nerves to the plexes, lumbosacral lumbar plexus going down the leg, they're from the primary ventral branch. But what about the nerves from the cauda equina that go to the primary dorsal branch? Wouldn't they be affected as well? Well, of course it would be. We just don't think about it. So how would exercise affect the primary ventral branch? Would be the tired legs. How would the exercise affect the primary dorsal branch? It would affect their low back, wouldn't it? Because that's where the nerves go. So I tried different procedures. It didn't help the low back. So let's say maybe it's due to neurogenic claudication, but in this case, neurogenic low back pain, lumbalgia, say. I just made that term up. So how do I test for that? Well, let's do a stenosis procedure. Remember this one? Some flexion in the lumbar spine. She protects her ribs with her hands, so I'm flexing the lumbar spine. I change the direction to what she likes. As I load, I continually ask consent during the procedure. Oh, my legs feel, oh, my back feels warm. She stands up, she walks around, her back's better. Not bad. Now, suppose I tried this and it didn't work. What's the other differential diagnosis it might be? Well, believe it or not, we talk about like back referring to the hip, but quite often the hip pain can refer to the low back. How can we tell if the hip pain is referring to the low back? How can we tell if that's what the low back pain is from? We can test for it. Would you kindly lie on your side so you face me this way? I'm going to actually flex the neck of the femur. Suppose your low back pain's on the, let's suppose in this case it's on your right. Slide it way up towards your head. Way up, okay? Yeah, towards me a bit now. No, this way. Straighten this out, okay. Now I'm going to flex your femur, neck of the femur, and as I do this, I'm going to see if this refers pain to the back. She feels the pain back in there. Now I'm actually flexing her femur. You feel that? Where do you feel the pain when I do that? You want to point to where you feel the pain? Okay. As I'm loading the hip, you notice I'm not moving the hip joint at all. But as I'm loading the femur, the neck of the femur is referring pain to the back. I'm not moving the lumbar spine. I'm not moving the sacroiliac joint. All I'm doing is affecting the nerves within the cortex of the bone of the neck of the femur. That refers the pain to the low back. I know that's what it's from. Patient gets a warming sensation after, stand up, back pain's gone. This isn't going to be the case with most back pains. What would be my clue to this being the cause of the low back pain? Probably they have some restriction or some pain within the hip as well. Restricted range of movement. Every time he talks about sacroiliac, sacroiliac, sacroiliac. Person comes in with low back pain, sacroiliac pain. Chronic knee pain, we know now with degeneration in the knee that the pressure in the interosseous subtibial table is too high, lack of blood flow in the cortex of the bone. Well, maybe you got a problem in the sacrum. Maybe the pressure at the subchondral bone of the sacrum is too high and that's causing the back pain. You never heard of that before. How can I test for that? Well, I can bend the sacrum. Well, how in the world am I going to bend the sacrum? I can't get my hands to it. Well, we can squeeze it. We're going to compress it. So now I lift this up a little bit further. Now it's compressing. It's compressing. Feel that? Now I can change your position a little bit, forwards to backwards, until I reproduce the pain. It's a little finicky because you only have to move the patient maybe an inch or so, and that's a totally different pain sensation. Can I go a little higher? And where do you feel that? Feels it right in the sacrum, right where the pain is. So I got to hold that. As I hold that, the fluid moves out. Then I let it go, relax a bit. Can I do it again?
Yep.
As the edema moves out of the bone, the range of motion of the bone increases, so it go to a greater level than before. Patient gets a warming sensation after, oh, my back's feeling better. Those are three kind of different aspects of low back pain. By using this method, you can differentiate. By using these tests, you can differentiate, and the case histories kind of give a good idea. With the sacral low back pain, it'll probably be tender right over the sacrum, because if the pressure in the bone gets too high, it's quite often tender to the touch. So that's a tip-off.